Good afternoon. Thank you to the ANS for having us, for our panelists for joining us today. For those of you who don't know me, my name is Erika M. Walsh. I'm a neurotologist at the University of Alabama at Birmingham, and I'm going to kick off our discussion this afternoon from mastoid to midline, cholesteatoma, and epidermoid cysts. Here are my disclosures, which are not relevant to today's content. So by way of introduction, I'm going to focus for a moment on intracranial epidermoid cysts. Everyone in this room is quite familiar with cholesteatoma, so I'm not going to belabor that piece. The first description of these intracranial cysts was by Crevillier in 1829 in his Anatomy Atlas. He described 3 patients with pearly intracranial tumors identified on autopsy. Typically, these are intradural tumors, about 90% of the time. They may have an intraosseous component and rarely can be intraaxial. They represent just under 2% of intracranial tumors. Intracranial epidermoids are in fact the 3rd most common tumor of the cerebellopontine angle, and for intracranial epidermoids, the CPA is the most common location. They can also be found in the paracellular and supracellular areas, the lateral and fourth ventricles, and the quadrigeminal cistern. One point we will emphasize today is that while intracranial epidermoids are histologically identical to cholesteatoma, they are a different disease. Their pathophysiology and clinical presentation are different. When I talk to my trainees, I oftentimes, especially when we're teaching them how to read MRIs, talk to them about it as cholesteatoma of the brain so they can remember the imaging characteristics, right? Who else is guilty of that? It's not, though, right? It's a different disease with different treatment. So epidermoid cysts arise from ectopic rests of ectoderm that are trapped during neural tube closure in weeks 3 to 5 of embryogenesis. And they end up in an intradural and paramedian location. These cysts have a well-defined capsule lined with keratinizing stratified squamous epithelium. The cyst itself is filled with desquamated epithelium, water, products of cellular degradation, which can be lipid or protein-rich, and occasionally blood. Malignant transformation to squamous cell carcinoma has been described. Intracranial epidermoids are typically slow-growing, and as a result, they can at times be large at diagnosis. They present typically in the 3rd to 5th decades of life, and most patients will have had symptoms a few years prior to presentation. Occasionally, these will be an incidental finding identified on imaging performed for other indications. Intracranial epidermoids fill the container that's provided to them, and what I mean by that is they tend to grow along paths of least resistance to slowly occupy their anatomic space. So they will travel along cleavage planes in the subarachnoid space into the cisterns, fissures, and ventricles. In contrast to cholesteatoma of the middle ear and mastoid, they don't typically erode or expand bone. They will, however, envelop important neurovascular structures. The capsule can be difficult or impossible to dissect from important nerves and vessels without compromising integrity or function. And this stickiness may be compounded by a local inflammatory response due to intermittent cyst capsule rupture and spillage of contents. This behavior is in fact distinct from ear canal, middle ear, and mastoid cholesteatoma. The image on the right is an H&E slide. In the top left panel, the black star is normal brain tissue. The red arrow points to keratin debris in the lumen of the cyst, and the black arrow points to stratified squamous epithelium. Presentation of epidermoid cysts varies depending on their location and size. Sometimes patients present with nonspecific symptoms such as headache. They may present with seizures. They may have focal cranial nerve dysfunction. Aseptic meningitis has been described not uncommonly in these lesions. And they may even present with communicating hydrocephalus. Trigeminal dysfunction is quite common in CPA epidermoids, and up to 70% of patients in some series. In this setting, trigeminal neuralgia is felt to be due to either compression directly from the cyst, displacement of adjacent vessels onto the trigeminal nerve, or chemical neuritis. Just under 1 in 5 patients will have facial nerve dysfunction, and a small proportion of those will have hemifacial spasm as their manifestation of this. And as with other CPA angle tumors, hearing loss and vestibular symptoms are common, on average present in over half of patients. I want to talk briefly about imaging of epidermoids before we move on to our case discussion. CT imaging can be useful for both cholesteatoma and epidermoids, but in epidermoids in particular, they may be missed if they are small. Bony changes, as I've already mentioned, are uncommon, in contrast to cholesteatoma. They appear as a homogeneous lobulated mass that's iso or hypodense to spinal fluid, about 0 Hounsfield units. Rarely they can hyperattenuate depending on the cyst contents, and these are termed dense epidermoids. They typically do not contrast enhance, though a proportion may have a minimally enhancing rim, and calcifications are occasionally seen. These are two of my patients. On the top right image is a young lady who got a CT head for headache and was found to have a left cerebellopontine angle hypodense mass with displacement and compression of the brainstem. On MRI, this was confirmed to be an intracranial epidermoid. The bottom image is a patient with opacification deep to the labyrinth and adjacent to the sigmoid sinus and a canal wall down cavity with bony erosion. This is recurrent cholesteatoma. Last, I want to talk about MRI, which is an important tool in diagnosing epidermoids. MR characteristics are similar to that of spinal fluid. Both intracranial epidermoids and cholesteatoma have prolonged T1 and T2 relaxation times, and as a result are hypointense on T1 and hyperintense on T2. Rarely the inverse can be seen in lesions termed white epidermoids that have a high protein or lipid content in the cyst, and those will be hyperintense on T1 and hypointense on T2. They typically do not enhance with contrast. As a result, they can be difficult to distinguish from arachnoid cysts intracranially unless DWI and FLAIR sequences are obtained. On those sequences, they will have a higher than CSF signal. So all four images here are from the MRI on the same patient. The top left is a contrast-enhanced T1 sequence. The top right is T2. Bottom left is DWI, and bottom right is FLAIR. And you can see the classic T2 hyperintensity, diffusion restriction, and FLAIR increased signal consistent with an intracranial epidermoid. So with these concepts in mind, we'll turn it over to our case presentation and discussion with our panelists.
Thank you for setting the stage. So we're going to focus on epidermoids. I had a few other cases that were intracranial. We had a neurosurgeon who unfortunately was not able to make it, and so I took out some of that to spare you guys up here. Just to introduce the panelists, we have Dr. Angeli at the end there, next to him, Dr. Kutz, Courtney Voelker, and Babu. So thank you all for joining. The first case is a 24-year-old third-year medical student. He was having headaches, led to an MRI, which led to the images that you see, diagnosed as an epidermoid. The imaging, I'm not going to trick you guys on imaging. Basically, on this one, what you see is what you get. It's a right cerebellopontine angle lesion. It extends just to the porus acousticus. It's very punched into the cerebellum. Other than the headaches, the patient is completely asymptomatic. So the first question is, and I realize there's no definite answer on this, but are the headaches related to the epidermoid? You want to start with that?
Yeah, well, thanks for the inclusion on this difficult panel.
My pleasure.
I think headaches, in my experience with epidermoids, is that it can vary in presentation and that they seem to be incidentally found many times like this for headaches. I think sometimes we chase that and try to treat the headache by removing the epidermoid, which I think is surgically indicated. I don't think you can just live with an epidermoid potentially because it can grow and you have to monitor it. But I think trying to cure headaches by removing an epidermoid is fraught with some problems. I think especially if it's more anterior or midline, it's close to the trigeminal nerve itself. I think you run into problems with that, and I think it mimics migraine quite a bit also.
Yeah, so it's always hard to know, isn't it? So this patient has a tumor. They're 24 years old. They feel completely normal except for headaches. And you're talking about, well, we could do a craniotomy and take it out, or we could do nothing, right? So timing of intervention, I think, is another conundrum. So Dr. Angeli, would you operate tomorrow? Would you operate next week? Would you say, you feel good, we're just going to re-image you at some point? And how do you make that decision?
Well, again, thank you for including me in the panel, but I also want to thank you, Colin, for presiding on such a great meeting today. We've had a wonderful meeting, and I thank you for that. Especially, I was very impressed at how efficient and quickly you dealt with the business meeting this morning, so thank you. Well, I mean, this is a conversation you have to have with the patient. He's a medical student. Probably he can't afford taking time off in the middle of a semester. Maybe he wants to delay the surgery or the treatment, or it's essentially a shared decision between the patient and the surgeon. Headache is a difficult symptom. I would probably try to engage a neurologist and work out whether the headaches are due to these poor medical students, a horrible schedule in the wards or exams, whether it's related to the tumor. But if we can manage the headache symptomatically and we can wait for a better time to do surgery, I mean, I think I'm up for it.
Yeah, I'm shared decision making, sure. But but they're like, well, what do we do, doctor? So when would you say that a good time would be?
I think I would do it earlier rather than later. I'm concerned that he's 24, already has a sizable tumor. This is likely to continue to grow. He has a long time, long life expectancy. And this tumor right now is in a location posteriorly to the ISE mostly, if I see correctly. I think it would be amenable to a retrolab approach and probably relatively good chance for a near total resection. I would counsel my patients, and you probably have had the experience that most of these patients require reoperation sometime later in their life.
Dr. Voelker, do you agree with them, or is that all nonsense?
No, not nonsense. So I agree. These have a high chance of having a subtotal resection, leaving any trace behind. That there's always a balance of you don't have symptoms now, and so you have a good chance of getting a near total resection in order to possibly prevent any further symptoms. I would also counsel him to be prepared that the headache may not go away with the neurologist's help as well.
So this is from Dr. Link's op note. I just liked it because I would hammer away at him a little bit. You just have to channel your inner neurotologist when you're taking these things out and treat them like we do in the ear, which is work carefully on the capsule and take it out. And I would remind them that we operate on a mobile foot plate and the exposed facial nerve and the labyrinth. I think it finally settled in. And so the question of curable or not curable, I was certainly, the conventional wisdom was they're not curable. But I don't think that that's always true, right? It's size dependent for the most part. But Dr. Kutz, what do you think?
Well, yeah, thank you for the invitation. This is a tough panel. Yeah, I mean, a lot of these cerebropontine angle, like this tumor, our neurosurgeon would probably do this case. We may drill a ISC out. I think there's a chance it could be curable, but I would certainly counsel the patient it's likely there's going to be residual disease. These were generally congenital. Cysts have been growing for years, and so even if you leave some behind, it's going to be many years before they need treatment again.
Yeah, I always hope it's long enough that I don't have to reoperate.
Yeah, right. I wouldn't tell them that, for sure.
Anyway, we did surgery, agreed to, we don't delay. I think in terms of timing, from our standpoint, it's been intervene when it's as quickly as we can, basically. And your best chance is early on of preserving function. We'll talk more about that. So he got through all of that okay. His headaches didn't change, and as you can see, didn't become a neurosurgeon or neurotologist.
He became a neuroradiologist, right?
What's that?
A neuroradiologist?
It could be. I actually don't know. And true to form, we have pretty good follow-up. I tried to take patients that were a long time ago, and so I could get as long a follow-up because these require a long follow-up. And our last contact after the 12 years, we were like, get another scan in 5 years. And that was a few years ago, so I don't know what the status is. This is a 33-year-old nurse practitioner, very mild right trigeminal neuropathy, has a pretty complicated lesion on the scan involving the Meckel's cave along the trigeminal nerve, deeply erodes into the petrous apex, and kind of spills into the cerebropontine angle. And I have two questions on this, really. Here's a video that shows the extent of the tumor a little bit more. very inferior in the petrous apex. And so I just wanted people's thoughts on the approach, as we debated this quite a bit. So you want to tackle that to start?
It looks like it's quite inferior, so you may have to do a combined approach. It looks like you may have to go middle fossa, may have to add something to try to get to the posterior fossa. I'm trying to see if anterior you could go transsphenoidal or not. Not that I would do that, but it doesn't look like maybe you have access that way, because sometimes you can get decompression. I think the real issue with this is their symptoms are trigeminal neuralgia. She has this issue, and are you going to be able to make it better? Because trigeminal neuralgia, in my experience, is one of the tougher ones to take care of, especially when you have an epidermoid in that region, much like a trigeminal schwannoma. It's a challenge. Are you going to make them better, worse, or the same?
She had a 1 and 4-year-old at home, and so we ended up delaying, and she had progressive facial trigeminal neuropathy. We operated 2 years later. She had quite a bit of V1, V2 symptoms at that time. And we could not really divide. I clearly had to go middle fossa, but knew I was not going to be able to get inferior enough, and we knew there was some in the CP angle we really weren't going to be able to get to. So we ended up doing kind of a combined, unusual approach of 2 separate craniotomies. But that's what we did. Go ahead.
Maybe I missed it. What was her hearing again?
Normal.
Oh, okay.
Yeah.
It wasn't normal. I guess you could transodic maybe or
Yeah.
something like that.
Yeah, that would have been easier.
But yeah, too bad. It's always normal.
Interestingly, with her trigeminal nerve is very deflected into the petrous apex. I thought for sure it's going to be pushed superiorly and medially, and it'll be, okay, but it was actually down into the bone and the clivus and the petrous apex. So she was quite a bit worse afterwards. This is her scan over time. So 2020 was on the far left is your pre-op, the 2022 post-op, and then the last couple post-ops. There's no question there was disease left. We had trigeminal nerve was problematic in terms of really curetting and addressing the petrous apex, and of course getting it out from under the carotid, et cetera. When would you intervene now? Because this is going to grow, but do you let it fill the petrous apex? Do you let it spill out into wherever? Do you wait until she gets new other cranial neuropathies?
What symptoms does she have now?
Just V1, V2.
Same what she had before.
Yeah.
My opinion is I would just watch it until she developed other symptoms.
I agree. I'm going to keep moving on. I'm not going to operate on her again. One of you guys can do it. This is a really fun case, interesting person. 2008, at age 7, she presented with some mild hearing loss. It's not that audiogram that's there. And a CT scan was obtained, and she was diagnosed with cholesteatoma, and the mom was saying, yeah, they had some discussion about it and said, well, you really have mild hearing loss, we'll just follow it, which was always a head scratcher, but you'll understand why. And so they observed it. She didn't really get very regular follow-up, and at age 14, she was seen again by somebody, and they offered surgery. She had some hearing loss, which is probably more like this maximal conductive loss. But they're like, I can't guarantee I'm going to get the hearing better, and she otherwise feels fine, and so they decided not to do anything. And then in 2023, she presented again at age 22 and proceeded with surgery. And the plan was intact canal wall down, or canal wall up, tympanomastoidectomy for cholesteatoma. And intraoperatively, the surgeon recognized pretty quickly that this involved the facial nerve and extended medial to the labyrinth, and this was not your run-of-the-mill cholesteatoma. And made the intraoperative decision to do the canal wall down and leave disease behind. And one of my questions, maybe Courtney, I'll ask you this. We run into things that are surprising during our operations, and I wanted to know, do you have a systematic thing you do or random thing you do to okay, now what do I do? How do you sort of reset, re-diagnose, and replan your next steps?
I think for me, it starts before the surgery. So making sure that I really counsel the patient on all the potential complications, all the potential reiterations, talking about starting with canal wall ups, trying to save that canal wall, but having to take it down, and then going through each structure with the patient, with the family, about all the things that could happen, could be injured, could have ramifications. And I think that makes it a little easier in the operating room. Oftentimes I'll call the family to have that discussion if I am seeing something unexpected. I take a lot of pictures in the operating room so that if I come across something that I didn't discuss with the patient, but I got consent with the family, that I'm documenting that not only for myself, but also that I think that makes it easier when you talk to the patient afterwards, because you didn't get to have that conversation, and then show them, this is what I encountered, this is when I called your family, this is how it ended, and then here we are. So I think that's helpful for me.
Dr. Angeli, and you're in a case and it's like, oh my gosh, this is a total pivot. I don't actually know what to do. I mean, I'll sit there and I'll irrigate a little bit. I'll talk to the residents and take a step back and see, okay, where do we go from here? What do you do?
Well, this is obviously a congenital epidermoid of the temporal bone. The majority of them arise from the Leslie-Michaels rest, the embryonal rest in the anterior protympanum, supratubal recess. So that's probably going to be the origin of your tumor, even if it's extending back in the mastoid. And in order to reach that area and be sure that you resect all the cholesteatoma, you need to be ready for a good exposure. And either, if you're very able and do it with your endoscopes, I typically end up doing a lot of canal wall down, so extended athecotomies as well as my, standard mastoidectomy with facial recess. I mean, the goal is to resect the entire tumor, and you can do that in the majority of cases. Then you need to reconstruct, especially on a younger patient. I do a lot of canal wall down reconstructions with a number of fillers and flaps, especially flaps with axial vasculature, trying to reconstruct the posterior canal, and then lifelong surveillance with, at least long-term surveillance with MRIs.
So she got through this surgery great. She had a little bit of dizziness, got back to baseline, hearing was stable, interfacial nerve was normal. And that picture is when I first saw her cavity. Oh, I should go back to that for 1 second. You can see on the picture, there's clearly cholesteatoma in the epitympanum, and also just posterior to that, over the horizontal canal. All of that is soft. This is some of the images from the scan, and there's involvement medial to the superior canal here with erosion in the labyrinth there. There's widening of the labyrinthine segment of the facial. It's all around the geniculate. There's multiple dehiscences into the vestibule and the labyrinth. You can see here it's all blown up around the facial nerve again and into the IAC. And this was, I'll just run a couple of images here. The one that's running right now is actually the very end of taking out the last bit of epithelium, I hope. And then I'll run the other one in a minute too. But this is the horizontal portion of the facial nerve, geniculate, labyrinthine segment, and then the distal IAC is here. By this point, most of the labyrinth has been drilled away and is filled with bone wax. So I just wanted to pick your brain there, Walter, about...
I actually had a very similar case a few months ago. I had
good.
I had 3 of these come up, so we'll see if I did okay.
So
they're all doing great.
I have one of these
No
too,
recurrence.
so I was thrilled that this was on the.
I want to know your surgical tips. So, like, what instruments do you use? How do you dissect things out? Do you take it off the facial nerve or not? That sort of thing.
Yeah, I think a lot of it's dependent on the characteristic of the matrix. Sometimes it can be very stuck, especially if it's inflamed. Other times it'll lift fairly easy, but in something like this, there's always going to be a part of that nerve it's going to be very difficult to remove the matrix. I like annulus elevator. Sometimes a nerve stimulator just to torture everybody in the OR can be nice, that little blunt tip of the Prass probe. Sharp dissection, I think is okay. I think sometimes you can actually use directional irrigation and kind of hydrodissect or at least clean off some of the blood and make things easier to see. On this case, you're going to obviously tell the family, unfortunately, that the hearing's going to be most likely lost, although the one I did recently, they still have a bone line. That was pretty good, but it's going to eventually be lost. And I think our number one priority is to preserve the facial nerve, above all else. And I would tell them it's likely going to leave tumor behind. And I would close that ear and probably come back in it some other day. I think if you think you resected most of it, or you're very close to near total, or I think doing an MRI sooner than later, and if there's a small residual disease, you may go after it sooner than waiting for some years, just for the chance of maybe a cure, kind of do a second look type thing.
Would you do this would you do it middle fossa?
I don't think I think you drilled out the labyrinth, didn't you? Yeah, the disease is already, I would not do middle fossa.
Would you have gone translab and say, I'm just going to take the hearing? Yeah,
I would have.
Would anybody have done it middle fossa? When you do a middle fossa case,
Are you talking about somebody with normal hearing?
Yeah, she had good bone line.
Yeah, the thing is you have a fistula of the cochlea. If you're going to remove matrix of the cochlea, that's a dead ear, 99.99% of the times.
Okay.
I mean, I would repair a fistula if it was a type 1 or type 2 fistula when the matrix is not attached to the membranous labyrinth. But in the cochlea, that doesn't work. I mean, and you leave the matrix, it's going to be dead.
Let me wake up the audience. If you're doing a middle fossa craniotomy for I don't care what reason, you're just doing it, do you stand or sit? Do you stand?
Squat.
Why would you?
Stand or sit.
How many sit? Sounds like most people
sit.
sit. Yeah. I've never been able to figure out a comfortable way to do it. Either way, I start to hurt after a while.
Hey, Colin, we're otologists. We sit. I mean,
I know, but my arms are short. All right. So this case, I was done. I felt pretty good about it. We closed the craniotomy. I did it all through a middle fossa craniotomy. I didn't elevate or cavity. I didn't do anything with the cavity except, of course, get like a 2 millimeter hole through where the cholesteatoma is up against it. So I close everything, pack with fat in the craniotomy, close the craniotomy, look in the cavity, figure out probably just put some packing in there. And the fat is kind of prolapsed into the cavity a little bit, and she's leaking spinal fluid into the cavity. At which point, I'm like worn out. And the last thing I want to do is open up the craniotomy again and repack all this. So I'm trying to figure out how can I pack this cavity and because if I push on it, I push the fat back or leak stops. And like, how can I keep that? I'm trying to figure out a way. And the resident's like, well, how about just using Xeroform? I was like, oh, brilliant idea. So I packed it with Xeroform way tightly. She didn't leak in the clinic, and didn't leak post-operatively, and remarkably, did well. Her hearing, her hearing's her hearing. Her bone line is unchanged, which makes no sense. But the reality is we get away with stuff that we shouldn't get away with sometimes. And so I have a very hard time giving up on hearing. Sometimes I regret it intraoperatively. Why didn't I just go translate?
Yeah, I mean, that's amazing that you're able to do that. I was going to point out with extensive disease like this, sometimes you have to sacrifice something, and we don't want to sacrifice, meningitis. We don't want to sacrifice the facial nerve, and hearing would be the one thing you would sacrifice.
I had pretty much given up on it mentally in surgery, but again, I just kept drilling bone away to get to the cholesteatoma.
I just want to make a comment.
Yeah.
In terms of the MRI surveillance, I usually delay my first MRI to 1.5 or 1 year after the surgery, because you may, especially if you don't have at our institution, we use a non-equiplanar DWI, which is more sensitive than the regular DWI. But you may miss a small residual cholesteatoma if you scan too early and be falsely reassured.
Yeah.
So I usually wait a year and a half to do my first MRI, and I do another one at 5 years, because there's been cases of negative initial MRIs, which then turn positive a few years later.
Yeah. Any other comments on that, or should I move on? Moving on.
Just
Go
a quick question. Any consideration to just trying to overclose the cavity? I recognize that patient had a canal wall down and a meatoplasty, and so that might be technically challenging.
It was a backup plan. It's just more work. And you got to take all the skin out of the cavity too and close the canal.
I'm just really impressed that it didn't leak.
Yeah, that's what I did with the similar. I just closed the cavity, and I didn't do a translab. I just followed the disease and peeled the matrix off the inner ear and put some tissue over that, and they maintained hearing. But I did close the ear off and just put a abutment bone anchored hearing aid, percutaneous.
I like the metafossa because I feel like the disease is more on that side a lot of the time. So I try to look at where's the epicenter with respect to the facial nerve, and then come from that direction. All right, this case, 8-year-old, past her newborn hearing screening, if you believe that. Later diagnosed with this conductive bilateral hearing loss, which I'm sure was present at birth. She had multiple sets of PE tubes. Her hearing was okay. She was using hearing aids. And a CT followed by MRI confirmed a small right, what's called a cholesteatoma. Some of you might remember this one was on Doc Matter, and there was a fair amount of discussion about what to do. This is the images, and I'll do a zoomed-in image next, but she had about a 10-millimeter lesion, 9 to 10 millimeter lesion in the hypotympanum, and it eroded into the base of the cochlea here. And it was also just in contact with the carotid, not really involving that very much. And there was a bit of discussion about is this PE tube related or not, and then what to do about it because of the erosion. And this is a closer up view and on the photon scanner. And so you can see the base of the cochlea here, and you can see a thin rim of differentiation there, and then this lesion. So let's see, who hasn't had an opportunity to speak recently? Perhaps Courtney?
Probably me.
Courtney. The audience, yeah. What do you think, Dr. Voelker?
So I'm encouraged to see that thin rim. I would counsel about possibility of hearing loss, but encouraged by the thin rim. I would start with trying to take down the hypotympanic bone from the tympanic ring there while working possibly on both sides. So start with the canal wall up with the counseling of needing to take the canal wall down. And sometimes you can work on both sides, so from the middle ear side, and then also taking down maybe the retrofacial air cells and following the path along so that you can kind of see from both sides. So that's a possibility there.
Would you consider just following it?
I don't think so. I think it's just going to get worse, and especially I'm really encouraged with that little piece of bone there. You could save her sensory hearing, possibly.
Yeah, high risk, but yes, agree.
But if you leave it longer, then the risk is
100%.
going to be higher.
Yeah, I like your thinking. I'm good with that. Oops. So to make a longer story shorter, I didn't think there was any reason to delay either. I was worried about her losing the hearing. Maybe, again, we get lucky. Plus, if it involves the cochlea more, the possibility of a cochlear implant maybe gets more difficult as a backup strategy. And this did not look like a cholesteatoma to me. This behaved more like an epidermoid. When have you seen a 9-millimeter cholesteatoma, tube-related cholesteatoma, erode that much into the cochlea? It doesn't happen, right? It'll fill the space, and it'll grow and push the eardrum, but it doesn't erode so much bone. So I thought it was inevitable that she was going to lose her hearing. Why not take the chance? And so I took out I'm going to call it an epidermoid. We could debate the semantics. There were intraoperatively, I could appreciate this. It was all completely mobile. But it was a real layer and it never opened up into the cochlea. I actually had to drill the bone away around the round window niche as it was involved in the bone, which I think is probably closer to where it started. And again, I hesitated to show some of these because I lose hearing as well. I'll show you that on the next one. But her hearing remained good. She had had a ton of trouble with her hearing aids and ear canal infections and debris and drainage, and the family was very frustrated with that. So once we got her through this, like, well, can't you fix the stapes problem? I was like, oh gosh, last thing I want to do is do that. But anyway, we did that on both sides too. So she ended up doing bilateral stapes eventually.
How did you approach it? How did you get it?
I just did a post-auricular incision, transcanal, and then canalplasty. And it wasn't hard to see, and came off. It was very little on the carotid, so it came off of that easily. It wasn't difficult to remove. It's a relatively small lesion. But it was difficult decision making. Go ahead. Yeah, I think that's a semantics thing. That's part of the reason for the panel. So we would call this a cholesteatoma. It's a skin line cyst, right? But these in the temporal bone, some of these things we call cholesteatomas, I think, are epidermoids, and we have to think differently about how we take them out. Mostly they're around the facial nerve and the labyrinth, and they can present like cholesteatomas. They look like, it's like a congenital cholesteatoma. Why do we call it a congenital cholesteatoma? It's an epidermoid, I think.
So you think there's two different problems? There was
No, I think an epidermoid started along the base of the cochlea here.
and there's otosclerosis.
There was a skin rest there and developed into that.
Yeah, you say there's a skin rest there, and then it also had otosclerosis.
And then, oh yeah, she had congenital, bilateral congenital stapes fixation.
And she had tubes, is that right?
She'd had to.
I wonder if that, it could also be like a secondary acquired, maybe around the edge of the tube.
Could be, but have you ever seen that erode the cochlea?
I had a patient that was 70-something that had a retraction pocket, no debris, and we talked about it, and she wanted to, I got a CT scan, it was clear. She wanted to follow it, I thought it was reasonable, her hearing was good. 6 months later, she started getting vertigo, and so I got another scan, and between that 6 months of a clear scan and a repeat scan, she had developed a little cholesteatoma with a lateral canal fistula. And
It's
so
possible. I'll grant you, it's possible.
it's interesting, yeah.
Last case I have is a 31-year-old, age 5, or he'd had multiple ear sets, I'm sorry, age 5, he had the one set of ear tubes. He had periodic ear infections during his life and treated with drops, and things would resolve. Presented with normal hearing, no balance problems, and he'd gotten a CT scan elsewhere, which I'll show in a bit. He had this epitympanic retraction, and the CT was suspicious for a lateral canal fistula. I took him to the OR. It's like, this is a straightforward epitympanic retraction and cholesteatoma. And intraoperatively, I found things that I really didn't expect. I took out a lot of cholesteatoma up in the epitympanum and where he's retracted. And then as I was drilling down closer to the facial nerve and the labyrinth, I could see the skin in the bone, in these thin lines of what looked like epithelium in the bone. And I continued to follow it. So you can see like this here is skin. And eventually I ended up in the labyrinth feeling like if I don't take it all out, he's going to lose his hearing. And here I remove bone over, I peel off the bone, and you see epithelium. This is partially in the vestibule, but partially not in the vestibule. And then there's the last little bit right here of bone I was drilling and thinning out, and you could see this sort of line of white that I was tracking in the temporal bone, and you could peel that off. Needless to say, he did lose all of his hearing. He was a bit dizzy afterwards, but not that bad, actually, and that got better. But one of my questions with this one is, I'll let this play out here a second. That's otocapsule bone. And a multifunctional suction. You can lift bone off with it. But just pick this up, and there's skin. this is very clearly skin. That's a little less clear, but it's very unusual. I thought it was unusual. I looked back at his scan later, which I really hadn't looked at well enough in my mind. I look at it and go, wow, it's a poor quality CT scan. He's got an epitympanic retraction and a cholesteatoma. Well, let's go to the OR. And you could see on this the area that was suspicious for horizontal canal fistula, so we had talked about that and the risk of losing hearing, et cetera, right there. But I look at things like this, you go, oh, that's just one of those semicircular canals, but that's not a semicircular canal. This is a semicircular canal. And these little lines in here were some of the little lines of tissue I was following in the bone. And this right here, which sort of looks like a semicircular canal, is not. I didn't recognize any of that preoperatively. So have you seen this sort of thing before? I've seen it a few times up in the epitympanum and around the labyrinth.
Yeah, I've seen bone covering the cholesteatoma. For example, you take a cholesteatoma out of a mastoid and then you find bone and then you see cholesteatoma underneath as if there was some bone barrier between one cholesteatoma and the other pearl or a continuation of the pearl. So I have seen it before, yes, not in the labyrinth. I have a question for you of any one of the panel. Have you ever used chemical MESNA to dissect cholesteatoma? I know it's somewhat popular in Italy, where they use this chemical substance that is a mucolytic that breaks down the disulfide bonds to help you dissect the cholesteatoma of the mucosa of the bone. Do you have any experience with that, or?
No, where can I buy that?
Yeah.
You can buy.
What's it called again?
It's FDA approved, and urologists and spine surgeons use it, and it's not expensive. So I've never used it. I've heard about it. I've read some of the papers. No, they've done studies on animals and supposedly not ototoxic.
I have
and
read
there's
about
some.
that too. I don't know if anybody knows the name of it. I meant to
But
look
the
that
idea
up.
is it will help you dissect the matrix of the bone or difficult areas to reach.
Yeah. Sai, any insights to any of this here?
I'm sorry, what's the question?
Any insights? I mean, what's going on with this guy?
Yeah, I don't know, actually, and I don't know if I've seen a epidermoid that goes into the labyrinth, but as we know, it can get trapped in different cells like that, and I think in this case, I think you have to chase it up until you come to a point where you can't chase it anymore, and now you're stuck with imaging and monitoring for a period of time. If your question is, would you have stopped at the labyrinth, I think I would have followed the disease as far as you can go safely, and sometimes there are borders. I think what you're shocked about is that the scan imaging and the presentation is not as bad as what you found intraoperatively.
I think in hindsight I should have stopped, and he probably would have lost the hearing eventually, but it could have been a long time from then.
I think this is the kind of case, though, like he's sort of asymptomatic and he's got pretty bad disease, we'd call it. So eventually, if you don't, it's going to come back and probably get him worse than what he had before with some other type of symptoms. So I think being aggressive sometimes in that scenario is the appropriate thing to do.
Walter?
What sort of hearing rehabilitation did he pursue since he lost hearing? Do you think in
I think he
Baja
just-
or
I don't think he
Cochlear
did
implant?
anything.
Yeah.
Yeah.
What's the alternative if you stop? If you leave cholesteatoma, you have to do a canal wall down, right? Yeah.
Pardon?
If you had stopped and left cholesteatoma, you would have done a canal wall down procedure, wouldn't you?
I wouldn't. I would just leave it the way it is and follow him and go back, if and when it grows, assuming that he's going to lose his hearing, and you're going to have to go back and take it out. Just like if it was in the petrous apex, I wouldn't create a cavity that goes all the way to the petrous apex.
Yeah, then I would worry also leaving it, that then you're going to have chronic imbalance and he's going to be dizzy, and that's creating a whole nother set of problems.
Yeah, so I definitely shouldn't have stopped.
Yeah,
Like,
you did
yeah,
the good
thank you.
thing. Yeah.
You let your partner do the cavity care. That's the key.
Somebody was asking a question earlier. No. Yeah, I don't think in this case I could have exteriorized it all because it involved the labyrinth, and at that point, it's either take it out or don't take it out. If you do a canal wall down, then it's still it's not accessible, I think, to cleaning in the clinic, but I wouldn't disagree with people doing that for sure. I think you're going to be back at some point in time. It's easier to, for me, it's easier to go back when the ear is more normal. You have a TM and an ear canal, then you don't have to deal with the canal lining and all that. That's the last case. So go ahead. Oh, sorry.
Thanks, Colin.
Past president.
Two comments as the past president. No, I tend, these severe cases you just showed, I pretty much have resolved to do what Walter says, and I blind sack them and obliterate them and follow them with MRIs, rather than have a cavity with cholesteatoma around a facial nerve that you're cleaning out and their face twitches, and I've seen so many, and they do quite well, and then you follow them and then you go back in, and oftentimes it becomes a little pearl that's easier to remove. The body's sort of, once you get rid of the inflammation and everything. So I blind sacked in almost all these cases. And just about Mesna, which I first heard about at a conference when I was in northern Israel, and there's a panel, mostly Europeans, and everyone was talking about Mesna. And it's in everybody's hospital. They use it to prevent cystitis with chemotherapy agents. And so one day I had a big massy thing like this all over the place, all over the nerve. And I said to the resource nurse, can you get some Mesna? He says, I don't know, what's that? And he called up and the pharmacy had it. And so you just make a 50% solution and then you let it sit for a few minutes. I don't know if it helps you remove it, but both times. The second time I used it was in a case with cholesteatoma skin over the big giant dehiscent jugular bulb. And unfortunately, the child didn't have a venous system on the other side, so it was his only drainage system from the brain, even on a venogram, MRI venogram, and so I didn't want to sacrifice a jugular bulb, and so I just put some I got everything else done first, and slowly lifted it off the jugular bulb, and then put more Mesna, and then did it again, and more Mesna, and it went quite well. I mean, time will tell if I got everything, but so Mesna seems reasonable to use. It's common. I don't know if there's anybody from Europe or Israel here, but I think it's more common in Europe. There's some great articles in the pediatric literature, pediatric cholesteatoma literature from Europe, where it's commonly used and it reduces recurrence rates. So,
You just flood the space, flood the operative field with it, and wait for a period of time.
yeah, make a 50% dilution, fill it up, tell a joke or two, listen to some music, and then dissect some more, and then do it again, and it seems to work.
Hey, Tom, can I ask you a question? When you obliterate these ears, if there's no CSF leak, do you obliterate with fat or do you leave it open cavity?
I was always taught to use fat. I like the MRI imaging because you can tell fat from cholesteatoma, from other things. So I've always used fat, but my friend from Michigan told me that's ridiculous. We never obliterate, and I think, Colin, you don't obliterate much.
I don't.
Yeah, I always used fat.
I don't just you get in there, so it can be difficult wading through all that fat, but I was curious to see how you did it.
No, the fat comes out easily if you go back in, and
Thanks, Tom. Yeah.
Juan Kiosana from Miami. I kind of curious because that case where you have the epidermoid, which is right in the hippotympanoid, I have used endoscopes. I have the endoscope specific of lesions, specifically benign lesions on the hippotympanoid. And Walter is here. You are very experienced endoscopic. You would consider kind of make the approach and able to convert your approach to a proper endoscopic removal tool. What it means is that you make it to put the endoscope safely and try to do a surgery that can preserve the labyrinth.
Yeah, I mean, I think I'd probably try to start endoscopically, but I think you could probably do it either way with as much success. I think an endoscope's nice to look around those corners for sure. Sometimes, of course, you get around the corner and then trying to get to the disease is always difficult, and you probably have to drill away some of that bone anyway, but I think probably either way would work well.
Colin, I was thinking about your last case and that cholesteatoma tracking down between bones. Where I've seen that the most, I don't think this is the case in your case, is when you have templar sclerotic bone in the mastoid. If you you're doing a cholesteatoma and there's a lot of tympanosquatic bone, I think it's critical to lift all that stuff up. Otherwise, it'd be trapped right underneath it. The scary part is often when you move those little bones around, the facial nerve goes off, and you don't know if you're coming right off the facial nerve. But I've seen it many a times that the cholesteatoma will track between the layers of the new bone formant mastoid. So critical to pull it out.
Thanks, Anil. All right, thank you guys for participating.